I will present our first experience also on behalf of my colleague, Professor Aydin Hagikia, on using CAR T cells in myasthenia in Magdeburg. And here are my potential disclosures. And I think you have seen already this picture up there. And it's especially nice to be here today and to see how the field has developed within less than 4 years, which is a really short time period for what we are doing, actually. But it's also nice to see that some basic principles remained still valid and will remain valid, as also Georg Schett in his presentation pointed out. So there are things that you need to consider while you are working as a cell therapist. First of all, you have to pick the right disease. Then, besides that, to pick the right patient, to choose the right spot you want to hit and the right tool, and then to know how you will monitor the patient in terms of toxicity and efficacy. So I will try to guide you through those basic principles using MG as an example within the next 20 to 25 minutes. So myasthenia gravis, MG, is actually a prototypical immune disease. A couple of months before this photo was shot, I moved to Magdeburg, and I was very lucky to meet there Aydin Hagikia, our fellow neurologist and dedicated neuroimmunologist, which I contacted pretty early upon arrival and started discussing about potential use of CAR T cells in neuroimmunological disorders. And naturally, our thoughts and discussions were cycling through myasthenia gravis, MG, and I will show you why. First of all, it's a rare disease, right? However, despite being rare, it's the most common neuroimmunological junction disorder. And you have heard already some things about that by Professor Payne. So you have more women being affected than male, and you have peak incidences that are at a younger age, mostly affecting women, and at an older age, mostly affecting men. If you go into the pathophysiology, you will quite quickly notice why we were interested in treating MG. So what we know is that patients have pathogenic antibodies. This has been shown via multiple experiments involving immunoglobulin or serum transfers. And most patients, over 80%, have an antibody against the receptor for acetylcholine, ACH. And I will focus on those cases. So I will leave out MuSK, LRP4, which you have also heard about in the previous talk, which I'm very lucky about. So I don't need to explain you anything on that. So if you focus on acetylcholine receptor antibody positive MG, of course you need to understand what happens. So you see here a synapse, so we don't only have immunological synapses, we have also neuromuscular junctions or synapses. And in order to actually transfer signal from the nerve to the muscle, you need the transmitter, acetylcholine, which binds to its cognate receptor on the other side at the muscle end plate to trigger a signal. So in cases of AChR positive MG, you have antibodies against the receptor. And 3 key things happen. So those IgG1/IgG3 mainly antibodies trigger destruction of the membrane by activating complement. So it's also called a complementopathy, this disease. So you don't have this nice folding on your membrane, but it's flattening. Then you have receptor internalization upon antigen binding. So you lose your receptors that can react to the transmitter. And finally, what I thought as a student in the past would be the key mechanism, but it's not actually, you have the blockade of the signaling of the acetylcholine receptor because they compete for the acetylcholine. At the end, the problem is that you cannot signal and you have no muscle activation. So all muscle groups can be affected, and certain muscle groups are more prone to be affected, like the ones in the eye, the face, the throat, the neck, the limbs. And out of the muscle groups being affected, you have the typical symptoms. So the patients are fatigued, they have muscle weakness, they have a blurry vision, they cannot open their eyes properly, and in some cases they cannot swallow, they cannot speak very well. And there are certain triggers like infections that can lead to exacerbation of those symptoms, which at the end are called myasthenic crisis, which actually can lead to respiratory failure, and patients need to go to ICU and being ventilated. The treatment strategy for AChR positive MG is very well established, and for most cases it works. It's a progressive disease, so at one point it will need treatment. And as a first-line treatment, you try to block the natural degradation of the transmitter by blocking the esterase that mediates this degradation. So you just increase the concentration of the transmitter in the synapse. You can perform also a thymectomy. This is normally the case for early onset MG and in younger patients, because it's known that it's associated with thymic hyperplasia or thymoma, and you can really find B cells infiltrating the thymus, producing the autoantibodies and forming tertiary lymphoid structures. If this does not work, you move on to steroids. If this does not work, you move on to chemotherapeutics/immunosuppressions with, of course, considerable potential side effects in terms of susceptibility towards infections. 10 to 15% of the patients will be refractory to first, second, and third line, and there you start struggling. And I told you about the disease, and of course, as a clinician, you can have a lot of biotheories regarding how to treat a patient, but at the end, it gets down to the one patient, like in Erlangen with a young lady. So in Magdeburg, Professor Hagikia had one young patient. She is in her early 30s, mother of several kids, 4 to 5, living in a rural area of the northern part of our state, having been diagnosed with this disease over 10 years ago. And this patient had many muscle groups affected, and of course, this was totally detrimental for her quality of life. She could not barely handle her daily life. And when she was presented to us together with Professor Hagikia, she had an active disease, and her current medication was actually a proteasome inhibitor, so off-label use of proteasome inhibitors, steroids, and the classical inhibitor for the esterase. And as you can appreciate, in gray, she had received already a lot of the established treatments before, including B-cell depletion with rituximab. And as you can appreciate here in this figure, the situation was, clinically a bit delicate. So the team around Professor Hagikia was able to stabilize the patient. So you see here the so-called Basinger score, which is a surrogate for the clinical activity. It's a multi-component score that was here rising and had a kind of a period of, let's say, control. But you saw the obvious rise of this score. And if you go back and look at the score 18 months before, you see 5 times such a rise. And each time leading to this thunder, and this thunder indicates ICU and ventilation. So the team around Professor Hagikia anticipated that this whole clinical course would lead to such, again, a deterioration, worsening of the symptoms, and leading her to be, again, ventilated in a life-threatening situation. So we had the patient and we had a model disease. So we asked ourselves, okay, can we apply what we have learned and what we have seen in lupus and systemic sclerosis or in myositis in a patient with MG using CD19 CARs? So we had a look back at the pathophysiology. And as I mentioned, pathogenic antibodies have been described and have been associated with this disease. And if you look at the vast amount of literature that has been published and the work that has been carried out in MG, you see that it's a B-cell mediated disease which is also dependent on T cells and vice versa. So what you can appreciate here is, of course, the autoreactive B cells that at the end will produce probably the pathogenic antibody, but on the other hand, you have also T cells, especially T helper cells that produce interferon gamma, IL-17, or trigger via the CD40 signaling axis and activate the autoreactive B cells. And on the other hand, this goes the other way around. You have the B cells that can secrete cytokines, that can present autoantibodies, so they can act as APCs. So this goes both ways. So we're thinking if B cells are the right target and if we should also, be a bit hesitant because of the T-cell component, like also in lupus. And also as an argument, which we can discuss later, regarding using lymphodepletion in those patients, since we know that lymphodepleting agents are affecting activated T cells. We know this very well from stem cell transplantation and the use of cyclophosphamide there, and this surely applies also to autoimmune diseases where autoreactive T cells or activated T cells are more sensitive towards cyclophosphamide, for example. And regarding B cells as a target, this is not new. As we have heard today, B-cell depletion has been used in all kinds of autoimmune disorders. The same applies to MG. The results have been mixed. There are two late studies like the BEAT-MG study or the Rhinomax study that showed some efficacy, but mixed responses, and actually also very similar to what has been presented by Professor Payne, using actually rituximab at an earlier point might be a better choice, as shown in the Rhinomax study from Sweden. So why is B-cell depletion using an anti-20 antibody not working that well? Was the next question that we ask ourselves. And I think it's very obvious after the talks we have heard, the depletion depth is not as good as we would like it to be. We know that B-cells are depleted very well using anti-20 antibodies in the periphery, but we also know from a variety of autoimmune disorders that autoreactive B-cells are not eliminated in other compartments that well, like in the bone marrow, the lymph nodes, and probably also the synapse, because there is some work that indicates that B-cells can also locate within the synapse which formed between nerve and muscle. So here, CAR T-cells would be, of course, an interesting choice, since the biodistribution as compared to antibodies is faster. We know that they also actively move. There's no only passive motion. So this is a plus for using CAR T-cells, the first one. Then, I think you have seen now this scheme several times, and everybody will know at the end of this day when CD19 is expressed on B cells and when not. There are some things regarding the target. So CD20 is the target that has been used mostly by using rituximab, but also other CD20 antibodies have found their way in autoimmune disorders. And there are certain advantages in terms of CD19. And they apply in general to several autoimmune disorders, but also to MG in particular. And I will show you the next slide, so I will at least put something new on it now. So here. So as you've heard, you strike the pro-B cells, which are at a very early time point developing the bone marrow. And here, at the pre-B cell stage, in the transition to immature B cells, you have the first checkpoint in terms of autoreactive B cell compartment. So it's good, actually, from a very pragmatic point of view, to start replenishing your pool at an early time point. And I would say the earlier, the better. So this might be an advantage of going for CD19. Another thing is that there is work that has shown that patients that are resistant towards rituximab with MG tend to have autoreactive memory B cells that are CD20 low or CD20 negative. So it's good to get the memory B cells, apparently. And then, of course, as you've heard, plasmablasts and plasma cells are the population to go if you want to get rid of antibody-producing cells. And there might be some advantages or not, this is something we have to figure out, to spare the plasma cells in case they are not the one that cause the disease, right? Because by doing so, you might be able to maintain your vaccine titers, for example. And another thing that needs also to be taken into consideration is that you have tolerance-promoting B cells, the Bregs. And we know that in Myasthenia gravis, Bregs have quantitative and qualitative defects, right? The numbers are low and their function to control T-cell responses low too. So it makes sense, at least to me, to get rid of those B cells in order to replenish them with young, new one, baby B cells, baby Bregs. And many of the Breg subsets are CD19 highly positive. So there are 4 new arguments that speak in favor of going for CD19 and are supporting us in using this similar approach in MG. And as a very close collaborator tends to say, it takes a village. So we teamed up with several partners to try to help our patient. First of all, we teamed up with Kyverna. This is a company in the US that we were talking to in order to bring some clinical trials to Magdeburg in autoimmune disorders. And in this case, we asked them whether they were generously enough to provide us with a product in order to help our patient in need. And then we teamed also up with Bochum. Professor Ralf Gold is one of the experts on MG in Germany and the former mentor of Eidenhal Gikier, in order to have additional scientific support. And the product that we used is Kyverna 101. It's a CD19 targeting CAR T-cell. There are some differences as compared to the commercially available CAR T-cells at the moment. So one of the differences is that the antigen binding domain is fully human. And another difference is that you have the CD8 alpha hinge and transmembrane domain, which in combination with CD28 co-stimulation leads to less production of cytokines, because the ones CAR T-cell products that are approved and used combine CD28 hinge transmembrane with CD28 co-stimulatory domain. So those are the potential advantages. And yeah, so we, of course, as also Professor Magnussen pointed out, we're eager to see if we can produce CAR T-cells, or Kyverna can produce CAR T-cells from our patient after that many rounds of immunosuppressive therapy. And this worked very well. And as you can see here, in May 23, we were able to infuse CAR T-cell into our MG patient. And here you see the product. We were very happy to see that the CD4-CD8 ratio was in favor of CD8s. This is not often the case when you produce CAR T-cells. Normally you have a tendency of more CD4s, which at the same time are the ones that are, the ones that probably are more responsible for the side effects. And we had in our product bag a lot of stem cell-like memory cells, which also was very nice for us because we know that they have the highest proliferative potential. And we infused those cells, 100 million. In that case, 1.5 million cells per kilogram body weight. And we're eager to see whether those cells expand. And as you can appreciate here in this flow cytometry analysis, you see that in the upper right corner, the CAR T cells are slowly expanding and peaking at day 16. And then, as you have heard, there is a contraction and the CAR T cells disappear. And what is nice for me to see is that, that's why I also like to work on immune system. The immune system always seeks some kind of equilibrium. And I told you that we had less CD4 cells, but if you look at the expansion of the CAR T positive population in the patient you see that this peak is mostly mediated by CD4 cells expanding, and then again reaching a 1-to-1 almost ratio at the end. We don't know, of course, what this means exactly, but it's a nice thing to look at the moment. In terms of efficacy, we observed that B cells were gone. We saw that the pathogenic antibody was reduced to 30%, and this is interesting to see in MG. This is something I also learned while working with our neurologist colleagues, that it's a bit different than in lupus. The antibody titer is not correlating, at least the antibody titer for ACH receptor, not for MuSK, is not correlating with disease activity. So you can have patients with high titers and low activity, and at the same time you can see in the rituximab, for example, trials that you can deplete B cells, can get rid of disease activity, but at the same time have still a positive antibody titer, which is a little bit puzzling for me, for the neurologist, not that much, but which complicates things a bit further. But as I said, we can see a nice drop, but not a complete elimination of the pathogenic antibody. As we hoped for and expected, the titers for the protective titers for the pathogens the patient was vaccinated against were still there after CAR T-cell therapy, which made us very happy and confirmed our way to go for something that does not target long-lived plasma cells in this case. And in terms of clinical efficacy, you can appreciate here what happened to the patient. So these are some tests that we ran: arm holding time, walking time, showing the muscle strength. And as you can see here, the arm holding time improved very fast. The patient entered the clinic with a walking assistance. And then at one point, she noticed that her walking was improving using this walking assistance. Then she put it inside and started walking by herself, something she didn't do for the last couple of years, which she already started doing at our unit, which was impressive to us. And then you can get the clinical score. You see here this thunders and the increasing disease activity. After CAR T-cell infusion, the clinical score vastly improved. And here you can see 2 videos, because I think they are more impressive than the graphs of the patient before the infusion and 2 weeks after the infusion. So we had a clinical remission despite the presence of the pathogenic antibodies, and clinical remission was pretty obvious. In terms of toxicity, we have learned, of course, a lot from treating cancer patients, as you have heard. And of course, there are also biomarkers that have been defined that are related to toxicities. And here are some of the biomarkers. And of course, disease burden is much lower in an autoimmune patient, but several other things can be found in autoimmune patients, plus in our particular situation. So normally, you have an inflammatory environment when you treat an autoimmune patient. That's why you treat him. In our case, with the neuroimmunological disorders, you have pre-existing neurological conditions, which also pose an increased risk for developing side effects. We had, in our case, a CD28-driven CAR. We use lymphodepletion, including fludarabine. So there are several things that would speak for an increased risk for side effects. However, as also in the case of the case series that has been recently published by the Erlangen group, at least in this first patient, toxicity was limited. No CRS, no ICANS. Here you can see the leukocyte and the platelet counts, how it's increasing after lymphodepletion. Of course, you have a lymphodepletion-induced toxicity, but this is normal. I'm not showing you the hemoglobin levels because the patient came with a sideropenic anemia into the hospital and left it with a sideropenic anemia. So at least I can say you cannot cure or treat sideropenic anemia with CD19 CAR T cells. But that's why I'm not showing this yet. She showed a transient self-limiting transaminitis, which I think is more related to the chemotherapeutic treatment because she showed a similar pattern when she received bortezomib. And she developed a lymphopenia, which she maintained, a grade 2 lymphopenia. IgG levels were always over 5 grams per deciliter, which is nice. And actually, this patient developed also a COVID infection later on, many weeks later, and she coped with this COVID infection very well, which is, you could say, an adverse event, but of course, almost everybody in the room developed a COVID infection. But at the other side, it's good to see that she just needed some fluids to get over it, and that's it. So her immune system was coping very well with this infection. And as this worked very nice, and we had many patients that were in need and asked for such a therapy, and our cooperators were also okay with that. We continued and treated further patients, and you can see some of the accumulated data on that. And the nice thing that you can see that all patients show an expansion of CAR T cells. We had even a patient that had 2 peaks. At day 11, then CAR T cells showed a contraction, and then at day 22, an even higher peak, which is interesting to see, which I also cannot explain for the moment. And you see in all those patients, this multi-component score, this QMG score, going down. So we had a 100% response rate. And actually, we observed CRS grade 1 in the patient 2 and 3, which coincides, I don't know if it's a coincidence or it's mechanistically linked, with a very high proportion of CD4 cells in the product. In the first product, as I said, we had a CD4 to CD8 ratio of 1 to 2. In product 2 and 3, we had a CD4 to CD8 ratio that was between 4 to 1 and 6 to 1. So much more CD4 cells that we know can trigger autoimmunity. In terms of B-cell reconstitution, so of course the follow-up time is not that long, but we see B-cell reconstitution after 4 months in patient 1. So this is in this window of 3 to 6 months that we know from autoimmune disorder patients receiving CAR T cells. And so we are eagerly awaiting for the patient 2 and 3 to reconstitute. And regarding the immunoglobulin levels, you see that they might show a decline, but they remain over the 5 gram per deciliter. No IgG supplementation so far, and all vaccination titers were preserved. So in terms of what else is going on, besides our approach with CD19 CAR T cells, there were recently 2 publications I want to mention, and this is only refers to the ASHR positive MG, not MASP, because we've worked already with the AA CAR T cells, the new developments, which are very exciting. So there have been 2 publications that go another route in terms of the target antigen. So you have 2 anti-BCMA targeting CAR T cell approaches. So here you target the memory B cell, the plasmablast, and the plasma cell, not the earlier forms. And you see here, I mean, it's actually a single patient. This was the patient with, as in our case, with anti-tumor receptor positive MG, which shows a nice decline of the clinical activity of the disease, and at the same time also a nice depletion of the pathogenic antibodies. And then there is another study that is even more advanced in terms of introducing new things. So it's an mRNA-based CAR, so a transient CAR against BCMA. It's only CD8 cells in order to avoid toxicity, and it's given repetitively because of the transient nature of the CAR. You need to give several doses, so they give it 6 times, and the update of the study was published very recently, and you see what here they call a meaningful clinical response. So you see that the disease activity is reduced. Another advantage of this approach is that you can perform it in an outpatient setting, and they did not use a lymphodepletion. And this is, a question. I mean, in this case, it makes sense, but in general, as I said, I'm not that much against it. So to sum up everything, I think our work, our preliminary work has shown that treatment in this form of disease is feasible using CD19-directed CAR T cells. The toxicity profile is acceptable. Now we need to go back, and this is exactly what has been said before, to understand what we see here. So it really helps us to understand autoimmunological disorders. So to perform this bench side to bed and now back to the bench approach to understand what is happening, why antibody is still there but disease is gone. And what is of course very motivating for us is that the trial with Caverna 101 is planned for 24. So at this point I really like to thank you for inviting me, you for listening to me, and of course a great thank to all the partners that were involved in these approaches.